Hello everyone, and welcome to this session looking at medications. By the end of this session, you will have achieved a foundation level of knowledge of some of the drugs that we carry in the North West Ambulance Service and the indications, cautions and contraindications for these drugs as per JL-Calc guidelines. Further, it will help you to continue to build on your knowledge of which drugs can be used for certain patient presentations. This session complements your medicines management and optimization session. The drugs that we will look at today are within a technician's scope of practice, and therefore we will not be covering any intravenous paramedic medications. However, this shouldn't stop you from, in your own time, taking a look at what other medicines are available and start to build your understanding of the situations in which these medicines could be used. It may be worth mentioning that this session is a little PowerPoint heavy. Its intentions are to introduce you to the medicines and the situations in which they may be utilised. We will go into more depth into these medications regarding their pharmaceutical mechanisms of action in your pharmacology modules. To support this session, it's recommended that you have with you a copy of your JL-Calc app or book. Without further ado, let's get straight into the session. Whilst it is important that when we think about administration of medicines, that we follow guidelines, pathways and patient protocols, and what the difference is between these three separate entities, it is vitally important that we don't think of these things as a reading list of objectives. Drugs guidelines, pathways and protocols are there to support your clinical decision making, and it's up to you as the clinician to interpret the patient in front of you in order to tailor treatments. You must take time when considering all management and treatment options and explore the potential ramifications of making certain decisions. After all, let's remind ourselves that medicines are in fact poisons, synthetic drugs that alter and change the way our bodies function, sometimes for the better, but on other occasions not so. So let's start by taking a look at the 11 drugs that we're going to explore today. The mechanism of action for these drugs are very much different in terms of how they exert their effects on the body. For example, adrenaline, Entonox, glucagon, naloxone hydrochloride and salbutamol all use different types of receptors, whereas aspirin, GTN, ibuprofen and paracetamol all interfere with enzyme pathways to exert their effects. Let's now take a look at these drugs one by one. We will focus on the indications, contraindications, side effects and cautions of these medications. Let's start with the presentation of Adrenaline 1 in 1000. So Adrenaline 1 in 1000 comes in boxes of 10 vials containing 1 mg of adrenaline in a 1 ml solution. The ratio of adrenaline 1 in 1000 refers to the strength and concentration of the medication. Adrenaline is a sympathomimetic medication, that is, a substance that mimics or modifies the actions of endogenous adrenaline neurotransmitters of the sympathetic nervous system. As a hormone, adrenaline acts on nearly all body tissues. This is because adrenaline is a non-selective agonist, meaning it can act on both alpha and beta receptors within the body. It can activate almost all adrenergic receptors. Adrenaline acts by binding to a variety of adrenergic receptors. Adrenaline binds to these receptors, triggering a number of metabolic changes. For example, in the heart, activation of beta-1 receptors leads to an increase in contractility and cardiac output. In blood vessels, by acting on alpha-1 receptors causes vasoconstriction, increasing systolic and diastolic blood pressure. More importantly, however, adrenaline activates beta-2 receptors in the lungs, which leads to relaxation of the respiratory smooth muscles and bronchodilation. It's because of this mechanism of action and the effect that the drug can have that makes it perfect for its use in patients suffering from anaphylaxis and life-threatening asthma. Considerations when administering adrenaline 1 in 1000 include those patients who are taking non-cardioselective beta blockers such as propranolol, as this could induce severe hypertension. Similarly, adrenaline 1 in 1000 is not under any circumstances to be administered intravenously. Adrenaline, therefore, is administered intramuscularly, either into the anterior lateral aspect of the vastus lateralis or the deltoid muscle. Our next drug is aspirin. Aspirin presents in a tablet form, and typically the ambulance service carries aspirin in 300 mg doses per tablet. Aspirin is given orally and, dependent on the variety of medication, is either chewed or dispersed in a small amount of water. Aspirin is an antiplatelet medication or platelet aggregation inhibitor. It disrupts the enzymatic pathways that lead to the formation of platelets. The enzymatic pathways that are affected by aspirin can also lead to its antipyretic and anti-inflammatory properties. Aspirin is indicated for those patients showing clinical or ECG evidence suggestive of myocardial infarction or ischemia. What that means is that you do not have to have an ECG with ST segment elevation in order to administer aspirin. It might be that your patient has clinical evidence suggestive of cardiac chest pain, but no ECG evidence. In these cases, aspirin would also be indicated. Regarding the contraindications, aspirin allergy or sensitivity to aspirin is quite a straightforward one. Children under the age of 16 is an interesting one, however, and this is because children under the age of 16, aspirin may precipitate a syndrome called Reye's syndrome. Now, Reye's syndrome is rare but serious, and it causes swelling in the liver and the brain and has almost a 50% mortality rate. Reye's syndrome most often affects children and teenagers recovering from a viral infection, most commonly the flu or chickenpox. Although the risk of a child or young adult developing Reye's syndrome after taking aspirin are small, the effects of Reye's syndrome are too risky, especially when there are other medications on offer to help control pyrexia and joint pain symptoms in feverish children and young adults. Other contraindications include active GI bleeding, which I will talk about a little bit later on in the next slide, haemophilia or other clotting disorders, and severe hepatic disease, and these are all due to the disruption of both the clotting cascade and the enzymatic disruption that aspirin induces. As the benefits largely outweigh the risks of withholding aspirin, aspirin can be cautiously administered to those patients with asthma who are pregnant, who suffer from kidney or liver failure, have gastric or duodenal ulcers, and those who are already on anticoagulant treatment. In suspected myocardial infarction, 300 mg should be given regardless of any aspirin taken that day. Regarding the side effects, if you recall back to a few minutes ago where I was talking about how aspirin disrupts the enzymatic cascade, resulting in platelet inhibition, well, this enzymatic cascade helps to maintain gastric mucosa by stimulating mucus secretion. It also helps to maintain a happy level of anti-inflammatory prostaglandins. So when we take aspirin, by irreversibly blocking this cascade, it can lead to things like gastric irritation and decrease in the anti-inflammatory prostaglandins, leading to pro-inflammatory leukotrienes being released, resulting in side effects such as gastric bleeding and exacerbations of asthma, and why we must always give medication cautiously in these patients. Entonox is our first analgesic in this session. Entonox presents in a gas cylinder containing 50% oxygen and 50% nitrous oxide. It is self-administered by the user and safe for use in children so long as they are capable of following the administration instructions, and it can activate the demand valve. One thing to note is that the cylinder must be inverted several times before use to mix the gases when temperatures are low. Entonox is indicated for those who are suffering from moderate to severe pain as part of a stepwise analgesic regime. Regarding the contraindications, Entonox must be avoided in those who have sustained severe head injuries with impaired consciousness due to a possible presence of intracranial air. Decompression sickness, otherwise known as the bends, where Entonox can cause nitrogen bubbles within the bloodstream to expand, aggravating the problem further. Consider anyone who has been diving within the last 24 hours at risk. It's worth mentioning that you do not have to have dived particularly deep in order to get the bends. It can affect those who have been training in the likes of a swimming pool where they've had repeated submersion and re-immersion. Due to its effects, those patients who are violently disturbed psychiatric patients should not receive Entonox. Again, due to the properties of Entonox, those patients who have received an intraocular injection of gas, such as patients who have had ophthalmic surgery, Entonox should be avoided. And lastly, patients who present with abdominal pain where obstruction is suspected. This is because the bowel is a compliant organ and air trapping can increase the cavity and potentially lead to a rupture. Cautions in the case of Entonox include any patient at risk of air trapping, such as a pneumothorax, a pneumomediastinum, or a pneumoperitoneum, for example, those with polytrauma and a penetrating torso injury. The effect of Entonox can occur in about 3 to 5 minutes, taking approximately 5 to 10 minutes for its peak effect. Whilst there appears to be lots of contraindications and cautions for the use of Entonox, the benefits are great. For example, it's a rapid analgesic that has no cardiorespiratory depression, and it can be self-administered, and the effects wear off rapidly. The 50% oxygen concentration is valuable in many medical and trauma conditions, and it can be easily administered whilst preparing to deliver other analgesics. Let's now turn our attention to the treatments for patients who are hypoglycemic. Glucose 40% is our first treatment. It presents as a plastic tube containing 25 grams of glucose 40%. Glucose gel is administered via the buccal cavity, that's the area between the cheek and the gum, to diffuse through the oral mucosa and enter directly into the bloodstream. The action of glucose gel is simple and is to rapidly increase circulating blood glucose levels. As I've mentioned, it is indicated for known or suspected hypoglycemia in a conscious patient where there is no risk of choking or aspiration. There are no contraindications for the use of glucose gel, and the treatment can be repeated as necessary in the hypoglycemic patient. Caution must be taken, however, for those patients who have an altered level of consciousness due to the risk of choking or aspiration. Whilst this should prompt you to consider alternative treatments, you may attempt to soak a gauze swab with glucose gel and place it between the lips and the gum in an attempt to aid absorption. Our fifth drug is glucagon. Glucagon presents in a pre-filled syringe with 1 mg of powder in a vial for reconstitution with water for injection. You can see here in the picture the vial containing 1 mg of powder, and in the pre-filled syringe 1 ml of solution. The 1 ml of solution is inserted into the vial, mixed and then redrawn to reconstitute 1 mg in 1 ml of glucagon, ready for administration. Glucagon is administered intramuscularly, and its mechanism takes approximately up to 15 minutes to have effect, with a half-life of approximately 25 minutes. The mechanism of action for glucagon is quite complex, as it involves a number of stages with a cascade of effect. One of which is glycogenolysis, which promotes the breakdown of glycogen into glucose, and at the same time inhibits glycogen synthesis in the liver, averting further storage of glucose in the liver. Ultimately, however, the effect is to raise blood glucose levels. Glucagon is indicated for those patients who are hypoglycemic, have clinical or suspected hypoglycemia, or the unconscious patient where hypoglycemia is considered a likely cause with blood glucose levels less than 4 millimoles per litre. Glucagon is contraindicated in patients who are known to have pheochromocytoma. A pheochromocytoma is a rare, usually non-cancerous, that's benign, tumour that develops in the adrenal gland. You have two adrenal glands, one located atop of each kidney. Usually, a pheochromocytoma develops in only one adrenal gland, but tumours can develop in both. Glucagon for injection is contraindicated in patients with pheochromocytoma because glucagon may stimulate the release of catecholamines from the tumour, which may result in a sudden and marked increase in blood pressure, which may lead to multi-organ injury. It is also not to be given intravenously because of the increased chance of vomiting associated with intravenous use. Let's now take a look at some of the cautions. Caution must be taken for those patients who have low glycogen stores, such as recent use of glucagon or starved patients. Remember, the objective of administering glucagon is to convert stored glycogen into glucose. If the patient is starved, they will likely have poor or very depleted stores of glycogen, rendering glucagon ineffective, possibly delaying treatment. Secondly, those patients who are suffering from hypoglycemic seizures. This is because IV glucose is the preferred intervention in these patients for its mechanism of action and the speed in which the drug can reach its peak effect. Side effects of glucagon include nausea, vomiting, diarrhea, particularly in children, hypokalemia, that's low potassium, hypotension, and acute, hence hypersensitivity reactions, although these are rare. If you cast your mind back to one of the first few slides, you may recall me mentioning about the drug's guidelines, pathways and protocols, and how they are there to support your clinical decision making. But ultimately, it's up to you as a clinician to interpret the patient in front of you in order to tailor treatments. Well, the treatment of hypoglycemic patients is the perfect example of just that. When it comes to the hypoglycemic patient, you may have to make a choice dependent on your scope of practice, skill level, and the patient presentation between treating the patient with either glucose gel, glucagon, or considering glucose 10% intravenous infusion. For example, glucagon should only be administered when oral glucose administration is not possible or is ineffective, and or when IV access to administer 10% glucose is not possible. Glucagon is relatively ineffective in the very young, older people, undernourished patients, or those with hepatic disease, and those who have alcohol-induced hypoglycemia. If patients are having hypoglycemic seizures, then glucose 10% should be the first line of treatment. So we can see how when treating the hypoglycemic patient, it is vitally important to use all available clinical information to help decide between glucagon, glucose 40% gel, and glucose 10% intravenous infusion. The sixth medication we're going to explore is glycerol trinitrate, or as it's more commonly known, GTN. The presentation of this drug is in a tablet form containing 300, 500 or 600 microgram dosages per tablet. The dosage NWAS stock is 500 micrograms. It is a sublingual tablet, meaning it's placed under the tongue when administered. Another common presentation of GTN, which you may have seen in practice, is an aerosol spray, which is a measured dose of 400 micrograms, which again is delivered sublingually. An important thing to note is that with any nitrate, the principal purpose is to relieve pain associated with the disease process. That is, reduce vasospasm and restore coronary blood flow to the coronary arteries. GTN is a potent vasodilator, resulting in dilation of coronary arteries, systemic veins, and reduced blood pressure. So let's take a look at a pictorial representation of how this works. So let's take a look at how GTN works on the specific coronary arteries. So here we have a crudely drawn heart with some good coronary artery blood flow. If we introduce a thrombus in our coronary artery, it will cause coronary vasospasm around that thrombus, which will in turn reduce the blood flow through the coronary artery. And as we know, reduced blood flow leads to myocardial ischemia and chest pain. So if our patient takes a nitrate, this will cause vasodilation of the coronary artery, and if you vasodilate the artery around the thrombus, blood flow is going to be restored and you're going to get a resolution of ischemic chest pain. Let's take a look at the indications. So GTN is indicated for administration in patients presenting with cardiac chest pain due to angina or myocardial infarction when systolic blood pressure is greater than 90 millimeters of mercury. Breathlessness due to pulmonary edema in acute heart failure when the systolic blood pressure is greater than 110 millimeters of mercury. And those who have taken an overdose of cocaine and are presenting with chest pain. Our contraindications include hypotension, as we've just mentioned in those two specific cases, hypovolemia, as we can imagine trying to vasodilate somebody who's already bleeding from somewhere, and it's not going to be very helpful, head trauma, cerebral hemorrhage, that is stroke, the unconscious patient, known severe aortic or mitral stenosis, and lastly those that have taken sildenafil, which is Viagra and other related drugs within the previous 24 hours, as profound hypotension may occur. Some cautions include those patients with suspected posterior MI or right ventricular myocardial infarction as diagnosed on a 12-lead ECG, as these patients are very preload sensitive and it can lead to profound hypotension, ischemia and even death. However, like all medications, there are some side effects. We don't just get vasodilation in the blood vessels that we want, we also get vasodilations in the cerebral vessels, and that can cause slightly raised intracranial pressure as the vessels expand, and patients therefore can present with a headache. Another side effect, of course, is that these medications can lower your blood pressure, so patients may present with postural hypotension, dizziness, syncope, and falls. Moving on to a more familiar medication is ibuprofen. Ibuprofen, however you wish to pronunciate its name, presents as both a tablet which is taken orally containing 200 mg or 400 mg and a solution or suspension containing 100 mg in 5 ml. Typically in NWAS we carry 200 mg tablets as well as a suspension of 100 mg in 5 ml. Ibuprofen is a non-steroidal anti-inflammatory or NSAID medication. Its mechanism of action is very similar to that of aspirin in that it aims to disrupt the enzymatic cascade in order to produce its analgesic, antipyretic and anti-inflammatory properties. It's indicated for those patients suffering from mild to moderate pain, pyrexia with discomfort, as it may help to relieve the misery and often unpleasant symptoms that often accompany febrile illness such as aches and pains, soft tissue injuries, and is best used as part of a balanced analgesic regime. Regarding the contraindications, ibuprofen must be avoided in patients who are dehydrated, hypovolemic, have known renal insufficiency, active upper GI disturbance such as those suffering from esophagitis, peptic ulcer and dyspepsia, a woman in their last trimester of pregnancy, as this can lead to heart defects in children, a change in the amniotic fluid and an increased incidence of childhood asthma, a child with chickenpox, as it can cause the skin to become infected and develop a condition known as necrotizing fasciitis, a patient who has previously shown hypersensitivity reactions, for example asthma, angioedema and urticaria, in response to ibuprofen, aspirin or other non-steroidal anti-inflammatory drugs, a patient with active peptic ulcer and hemorrhage, and lastly, a patient with severe heart failure, renal failure, or hepatic failure. Two additional points are that you must avoid giving further non-steroidal anti-inflammatory drugs if an NSAID containing product has already been given within the previous 4 hours, or if the maximum cumulative dose has already been given. Also, do not give in the frail or older adults with fractures, as more evidence is being established to ensure that ibuprofen has no impact on fracture healing. Consider alternative analgesic options for these patients. Let's now take a look at some of the cautions for ibuprofen. I guess the big one that we should start with are those patients who are asthmatic, as ibuprofen can lead to possible hypersensitivity and bronchoconstriction. So try not to use acutely in the pre-hospital field if an asthmatic patient has not previously used NSAIDs. Use cautiously in older patients over the age of 65 that have not used or tolerated NSAIDs recently. Those with coagulation defects, as again this is all to do with the disruption of the enzymatic cascade and the effect on coagulation. Patients with Crohn's disease and ulcerative colitis, and lastly established ischemic heart disease and hypertension. Considering this is a medication that you can safely buy off the shelves, there are certainly a lot of contraindications and cautions for its use. Our next medication is naloxone hydrochloride, or, as it's more commonly known, Narcan. Narcan presents in an ampule containing 400 micrograms in 1 ml. It can be administered either intramuscularly, intravenously, or via the intraosseous route. Naloxone is a pure opiate antagonist used to block or reverse the effects of opioid drugs. Please note that Narcan only works on opiate medications. So what is it used for? Well, as I've just mentioned, Narcan is used for the reversal of acute opioid or opiate toxicity for respiratory arrest or respiratory depression, unconsciousness associated with respiratory depression of unknown cause where opioid overdose is a possibility, in cardiac arrest where opioid toxicity is considered to be the likely cause, and patients who have been exposed to high-potency veterinary or anaesthetic preparations should be given naloxone urgently if consciousness is impaired or exposure occurred within the last 10 minutes, even if asymptomatic. The aim of naloxone administration is to restore adequate respirations, but not necessarily to restore full consciousness. The only contraindication for naloxone is regarding the use of the drug in neonates born to opioid-addicted mothers, as this can produce serious withdrawal effects. Therefore, emphasis should be on bag valve mask ventilation and oxygenation. In patients who are physically dependent on opioids, naloxone may precipitate violent withdrawal symptoms, including cardiac arrhythmias. It is better in these cases to titrate the dose of naloxone to effectively reverse the cardiac and respiratory depression, but still leave the patient in a groggy state, with regular reassessment of ventilation and circulation. Vomiting is another common side effect following naloxone administration, emphasizing the need to ensure access to appropriate suction for these patients where necessary. Here are some examples of prescription opioid medications. It's not an exhaustive list, but gives you an idea of just how many opioids there are and that could be overdosed and therefore treated. Oxygen is our next drug. We've all probably seen this in one shape or form. Oxygen presents in a compressed form in a cylinder. It is fed via a regulator and flow meter to the patient by means of plastic tubing and an oxygen mask or nasal cannula. Regarding oxygen's mechanism of action, the main action of oxygen in the body is to precipitate in something called oxidative phosphorylation, which produces the ATP, which is energy required for cellular functioning. Oxygen assists in reversing hypoxia by raising the concentration of inspired oxygen. Hypoxia will, however, only improve if respiratory effort or ventilation and tissue perfusion are adequate. If ventilation is inadequate or absent, assisting or completely taking over a patient's ventilation is essential to reverse hypoxia. Oxygen is indicated for a plethora of conditions. Particularly in children, it is indicated for significant illness or injury. In adults, there are a number of indications. My advice would be to refer to the JR Calc guidelines dependent on the condition that presents in front of you. Generalized umbrella categories, however, include critical illness requiring high levels of supplemental oxygen, serious illness requiring moderate levels of supplemental oxygen if patient is hypoxemic, COPD and other conditions requiring controlled or low-dose oxygen therapy, and conditions for which patients should be monitored closely but oxygen therapy is not required unless the patient is hypoxemic. Other than where oxygen would be unrequired within those specific categories and subcategories, the only contraindication for oxygen is the use in explosive environments. A couple of cautions for the use of oxygen. Firstly, because of its properties, it can increase the risk of fire hazards at the scene of an incident. Similarly, in cardiac arrest, it is important that the pads are firmly applied to the chest to reduce spark hazard. Regarding the side effects, non-humidified oxygen is drying and irritating to mucosal membranes over a period of time. But more seriously, however, is that in patients with COPD, there is a risk that even moderately high dosages of inspired oxygen can produce increased carbon dioxide levels, which may cause respiratory depression, and this may lead to respiratory arrest. Our penultimate drug, and one that you're probably most familiar with, is paracetamol. Paracetamol presents in a number of different forms, including a tablet, oral suspension of different dosages, as well as a paramedic-only intravenous infusion. It might surprise you to know that paracetamol was first synthesized back in 1878. It is even more surprising to know that after more than 100 years, the exact mechanism of action for paracetamol still remains to be determined. But what we do know is that the properties of paracetamol produce both analgesic and antipyretic effects. Paracetamol is indicated for relief of mild to moderate pain, or similar to ibuprofen, a high temperature with discomfort, not just for a high temperature alone, however. Contraindications include patients who have had paracetamol allergies and those who have already taken paracetamol or paracetamol-containing products within the last 4 hours, or 6 hours in patients with renal insufficiency, or have taken the maximum daily dose. Side effects are extremely rare. Occasionally, systemic hypotension can occur if paracetamol is given too rapidly via the intravenous route. The last drug that we're going to take a look at is salbutamol. So salbutamol presents in nebules containing either 2.5 mg in 2.5 ml or 5 mg in 2.5 ml. After selecting the correct dosage for your patient, the nebules can be opened and inserted into a nebulizer mask, where the drug is nebulized with oxygen on 6 to 8 litres. In our lungs, smooth muscle cells are responsible for controlling the amount of airflow in our airways. Inflammation, allergens or irritants may cause smooth muscle cells to contract, causing the airways to become narrower, manifesting in exacerbations of asthma and difficulty breathing. Salbutamol is known as a selective beta-2 receptor agonist. This has a relaxant effect on the smooth muscle in the medium and smaller airways, which are in spasm in acute asthma attacks. If given by nebulizer, especially if oxygen powered, its smooth muscle relaxing action, combined with the airways moistening effect of nebulization, can relieve the attack rapidly. It is indicated for those patients suffering, as I've just mentioned, from an acute asthma attack when normal inhaler therapy has failed to relieve symptoms. Expiratory wheezing associated with allergy, anaphylaxis, beta blocker overdose, smoke inhalation or other lower airway causes, and exacerbations of COPD. Whilst there are no contraindications for the use of salbutamol, there are a number of cautions, and care must be taken in patients with hypertension, angina, hyperthyroidism, late pregnancy, as this can cause the uterus to relax and lead to early onset labour. Severe hypertension may occur in patients on beta blockers, and therefore half doses should be used unless there is profound hypotension. There are also a number of common side effects following administration of the drug that you should be aware of, including tremor, tachycardia, palpitations, headache, feeling of tension, vasodilation, peripheral muscle cramps, and a rash may appear. So now that we've taken a look at some of the drugs that you'll be exposed to out in practice, let's now turn our attention to safety. But why is this an important topic when we consider medications? Well, fundamentally, what we do, paramedicine, is by the broadest definition of the word, a dangerous undertaking. We have in our hands the ability to prolong, improve, and dare I say, save lives of patients. But when we can also cause them a great deal of harm. And there is no greater harm than administering the wrong dose, quantity, or preparation of a drug. So what is a medication error? Well, by the simplest definition, medication errors are any patient safety incident where there has been an error in the process of prescribing, preparing, dispensing, administering, monitoring, or providing advice on medicines. These patient safety incidents can be divided into two categories: errors of commission and errors of omission. Errors of commission include giving the wrong medicine or wrong dose. For example, giving 1 mg of adrenaline 1 in 1000 rather than the correct adult dosage of 500 micrograms. Errors of omission include, for example, omitting a dose, failing to dose, or failing to monitor, such as failing to monitor changes in patient physiology or failure to give accurate frequency of dosages. And this all comes at a significant cost, not only to the patient who may have had suffered undue harm, or to you as a remorseful clinician, but to the NHS as a whole. So how do medication errors occur? Well, they start with an individual, like you. And from this individual can come a plethora of factors that can contribute to medication errors in the clinical environment. Perception of risk is a good example that perhaps some of us can relate. Specifically, what we're talking about here is the perceived risk attributed to a specific drug in our arsenal. We may, for example, perceive paracetamol to have a low perception of risk attached to it, as a medication that is so easily accessible to the general public in large quantities. So we may only ask our patient surface level questions regarding the administration of the drug, such as, have you had any in the last 4 hours? Are you allergic to it? Before you then pop them a 1 gram dose. This level of complacency can lead you down the garden path, as it may be that it's not until later that their patient reveals that they've taken a cumulative 24-hour dose of 8 grams, and in effect you have just committed an error of commission. Another pertinent example revolves around drug knowledge. With the introduction of technology, there are now speedier ways in which information can be communicated with us through the likes of the JR Calc app. It is your responsibility to stay up to date with any changes in clinical practice. Take what might appear to be something as simple as oversight or not checking the guidelines can turn into a significant error of omission. So how can you minimise medication errors? Well, the answer is quite simply by doing the correct checks. More specifically, pre-administration checks, the 6 R's of medication administration, and the 7-point safety checks, which we will discuss on the coming slides. So firstly, the pre-administration checks. So first, check to see if the drug is indicated. Does the JR Calc or PGD allow this to be given to this patient in this clinical presentation? Secondly, the contraindications. Is the patient contraindicated for that medication? Allergy status. Does the patient have a history of allergy to this medication? Previous medicines. Check what other medications the patient may be taking and could it interact with the one that you want to give. Medication. Check the details including the name, strength, preparation and expiry. The dose. Double check you have the right dose and age for that patient. The route. Check to ensure that you have the right route selected and prepared it in accordance for that route. And always verify it with a colleague and say it loud. And some of these pre-administration checks are repeated in our 6 R's of Medicines administration and the 7-point safety checks that's coming in the next slide. So here are our 6 R's of Medicine administration, which are vitally important and a nice way of remembering pre-administration protocols. Always check, is it the right person or patient, the right drug, the right dose, the right route, the right time, and right documentation. And as for our 7-point drug safety check, this specifically looks at the drug itself and covers the drug strength and presentation, the packaging, the appearance, any damage or leakage, verification with another member of staff, the drug contraindications and allergies, and the drug name. And we can see how there's some crossover between all of these drug pre-administration and administration protocols. And it's a really good habit to get into as a student to undertake these safety checks prior to the administration of every drug, so when you do qualify, you are confident and a competent clinician. To finish off this session, let's take a look at some measurements and units and bring all of this information together. The importance of briefly touching on this subject is because, still on the theme of clinical incidents regarding medicines, every day mistakes are made in clinical practice across all health professions, and it's the patients that are suffering from simple things like getting the maths wrong, dosage wrong, or communication errors. Fundamentally, as paramedics, we need to be able to make accurate drug calculations in order to safely administer drugs. Ergo, we need to feel confident in our ability to conceptually understand units of measure, i.e. the difference between volume and mass, and competent in our ability to convert the units of certain drugs based on weight, age, and route of administration, i.e. grams to kilograms and kilograms to micrograms. Let's start by introducing units of measure. To begin, let's define what a measurement is, what it actually means to measure something. So in science, a measurement is the assignment of a numerical value to an object's physical property. Measuring physical properties such as length, volume and weight or mass are very common. For example, you might want to know the length of a line, the volume of a beaker, or the weight of a mass or a solid. Whenever we take measurements, we also have to assign units to that numerical quantity in order to convey the relative size or magnitude of the property in question. For example, if I said the length of my phone is 8, you wouldn't know how long my phone was, because there'd be no context for which 8 represents. In fact, the measure would only make sense if the number 8 had a unit of measure to go along with it. So what is a unit of measure? Well, in order to have an accurate and reproducible way of defining length, volume and mass, for example, scientists have developed various systems of measure. These systems are made up of units of measure, which are standardized amounts of various physical quantities. The SI system is the international system of measure used by scientists. It is a comprehensive system for many units of measure. For the purposes of this session, however, we will focus specifically on the physical properties of mass and volume. You can see that for each property there is a corresponding SI unit or base unit of measure. For mass, the base unit of measure is the kilogram, and for volume, the base unit of measure is the litre. To better understand the concept of converting units, it will be helpful to have a good understanding of metric prefixes, because the secret to understanding conversion is all in the prefixes. A metric prefix is a unit prefix that precedes, that's before, a basic unit of measure to indicate a multiple or fraction of that unit. So, for example, when we're talking about a kilo, which is a metric prefix, and what a kilo means, it means it is 10 to the power of 3 of something, which is 1,000 of something. Quick side note, when we talk about the power of something, like 10 to the power of, that means that it is 10 multiplied itself a certain number of times. So in this example, 10 to the power of 3 is 10 times 10 times 10, which is 1,000. So these metric prefixes can be applied to any unit of measurement. For example, a kilometre is 1,000 metres, a kilogram is 1,000 grams. So a kilogram is made up of 1,000 grams of something. This can also be applied to fractions of a number. For example, a milligram is 1,000th of a gram, so 0.001. To try and help visualize this, I have two identical beakers. Beaker A has 1 litre of fluid in it. Beaker B still has 1 litre of fluid, but it's made up of 1,000 millilitres. Remember from our prefixes that a milli of any unit of measurement is 1,000th of something. So in Beaker B we have 1,000 millilitres, which makes up our litre. So in other words, 1 millilitre is 1,000th of a litre. So if we times 1 millilitre by 1,000, we would get back to our original figure of 1 litre. Similarly, here, I have two identical bags of sugar. Only sugar bag A is 1 kilogram, and sugar bag B is written as 1,000 grams. So in our bag of sugar, we have 1,000 1-gram lumps of sugar, which is the same as 1 kilogram. So each gram of sugar is 1,000th of a fraction smaller than its combined mass of 1 kilogram. Therefore, each gram is said to be 0.001 kilograms. The importance of knowing how to convert units is that when we consider medicines and drug calculations in the future, it is imperative that you use the same unit of measurement throughout your calculation in order to accurately and correctly calculate drug dosages, something that you will cover in more depth in your pharmacology module. The last thing to consider is with regards to documentation. Here, we have a number of do's and don'ts when it comes to documenting medicines on paperwork, inclusive of the importance of the correct use of decimals. See, for example, the first point made regarding unnecessary use of decimals. See how 3.0 milligrams could be easily interpreted as 30 milligrams if read quickly. I will let you digest this information in your own time. Thank you, everyone. This concludes this session. I wanted to leave you, however, with this quote by Albert Einstein. Never memorize something that you can look up. Whilst we've covered a lot of information today, it would be an impossibility and impracticality to remember all of it. Whilst there is an expectation that you should have a firm grasp on the common indications and contraindications for all of the JR Calc drugs, your clinical practice guidelines are what will soon become your best and most relied on friend. My closing advice: know the indications for each of the drugs. Start to familiarise yourself with the side effects and contraindications of those commonly used, and learn the units and how to convert them. Thank you.